technology is being set up, I'd like to give a very warm welcome and introduce Pav Vegan. Pav with us. Hi. Hello. How are you? I'm the Pharmacy Information Officer. You're going to be talking to us about the future of digital medicines. Welcome. Thank you.
So, hi everyone, good morning. As mentioned, I'm Pat Deegan. I'm Chief Pharmacy Information Officer at North East London Foundation Trust. I'm a pharmacist by background. My presentation today explores how digital transformation is reshaping digital medicines practice, from prescribing and administration of medication to medicines reconciliation and patient access. However, we're not going to focus today at just looking at innovation. We'll examine it through the lens of interoperability, the standards, the systems and the connections that can make safe, scalable digital medicines practice fit for the future. So, what do we mean when we refer to digital medicines interoperability? Because this is going to have that medicine focus to it. It's the ability of digital systems across healthcare settings to seamlessly exchange, interact, and act on medicines-related data, ensuring that end-to-end processes of prescribing, dispensing, administration, and monitoring are safe, efficient, and coordinated. I just want to talk briefly about what do we mean by digital medicines and the systems that are in use across the NHS landscape. So I'll just talk very briefly about some of the applications that are already out there. So we have, and some of these you may already have heard about. So electronic prescribing and medicines administration systems that are used in secondary care for replacing paper drug charts, for example. So the prescribing, the administration, the supply of medicines within NHS organisations, for example. We have electronic prescription service, EPS, which allows prescribers to send electronically prescriptions directly to a patient's community pharmacy of choice. Closed loop medicines administration, which is the fully integrated technology-enabled process that enables safe, accurate, and traceable medicines management. It's designed to reduce medication errors and improve patient safety by digitally verifying each step of that end-to-end process of that medication journey. Summary care record, which is an electronic summary of key clinical information about a patient created from their GP record. So just to give you an example, core summary care record contains information about medicines that the patient's prescribed, but also allergy and intolerance data, which you can imagine is extremely important. You'll have heard of the NHS app, so a secure digital platform that NHS England has developed for patients that can access wide services from their smart devices. And just to give you an example in the context of medicines, the ability to order repeat prescriptions from your phone, from your GP. Shared care records, so bringing a person's health and care record together in one place from multiple organisations to create connected systems, providing joined up care. There are others, but I won't go into that. Now, what is the vision when we start talking about interoperability? We're talking about seamless, smart, standardised exchange of medicine data across care settings, person-centred medicines journeys with real-time interoperability across systems, so information available at the time it's actually needed for patients. AI-driven medicines optimization, and then that strategic alignment and policy integration. So why on earth do we need to talk about interoperability? Why does it actually matter? So there's inconsistency and fragmentation across digital systems. If we just think about the systems I've just spoken about, those digital medicines platforms that are used across the NHS and primary care as well, a multitude of systems just highlights the breadth and the diversity of the digital infrastructure across the NHS, just related to medicines alone. and these often operate in silos. Unstructured data, so a lot of free text entry around medicines, local codes in local systems, then mean that connectivity can't happen and information isn't transferable between the different systems that we use. And don't we all like a PDF attachment in an email? PDF attachments hinder automation and reconciliation. And you can imagine how important dealing with this is for the safety of patients. And where we have a lack of semantic alignment, so where the standards are not there, allowing different systems to be able to understand the information exchange that's happening across care settings. The result of all of this, as I've already alluded to, is that medicines data becomes fragmented, it's duplicated, or it's lost across transitions of care. The result of this, so safety risks from the lack of interoperability, mean that allergy and intolerance alerts are missed due to inconsistent coding across systems. Prescribing errors can result from mismatched product descriptions or unstructured entries. Reconciliation failures, and this is one of the key things across the transfer of care of patients between different care settings. For example, during hospital discharge, making sure the patient's GP is informed of any medication changes and the follow-up that is required beyond that, there can be a delay in that information getting to that patient's GP. Moving beyond that, AI prescribing tools, potentially being trained on messy or incomplete data, which can undermine safety and trust in the systems that we use. Linking all this in with digital transformation goals, the 10-year plan, the safer prescribing, patient empowerment and integrated care. Mandating structured transfer of medicines and allergy data across these systems. These are the goals that we want to achieve. AI readiness, medicines interoperability as the key enabler for safer, scalable and explainable use of AI in digital medicines, alternatively referred to as digital pharmacy. And then those patient-facing innovations. Usually the interaction with the patient is via the healthcare clinician. The patients need to be empowered to be able to look after their own medicines at the time that they need to be able to do it. This all depends on clean, interoperable data. Now, I just want to, I think I've just realised I haven't shared screen for those that are on the call via Zoom. A key enabler, I'm just going to talk now about the key enablers of interoperability. So these are the key ones for medicines interoperability. And some of these you'll already be familiar with across other areas of healthcare. So we've got the Fast Healthcare Interoperability Resource, FHIR. So this is about the data exchange framework. Just to give you an example in the context of medicines, transmitting prescriptions via electronic prescription service, so EPS, and I'll talk about that in a moment to bring it to life. SNOMED CT, the clinical terminology for intent and conditions. So we need to know what we're treating in the first place. So an example use case there is, for example, a clinician recording diabetes mellitus in a patient's medical record. There is a unique code that references diabetes mellitus. Focusing a little bit more now on medicines, we've got the Dictionary of Medicines and Devices, alternatively known as DM&D. This is a standardized dictionary of descriptions and codes for medicines and devices that are used across the NHS. Again, I've put an example there, just a simple example of the intents there. We've got diabetes mellitus recorded by the clinician. We now want to prescribe metformin 500 milligram tablets. That in itself has its own unique code. And then a medicines and allergy intolerance data transfer standard, the DAPB 4013. Don't we all like numbers and letters when it comes to standards? So the purpose of this is the transfer of coded discharge summaries as a use case example. So specific information related to the patient's medication. So I'm just going to talk a little bit about EPS now. So electronic prescription service, you may have experienced this if you go to see your own GP and the GP prescribes you some medication. Now, EPS is sometimes just seen as a transmission tool, but when coupled with interoperability, or leveraging interoperability can deliver safer, smarter prescribing. So starting with the GP that enters in the prescribing process, enters a SNOMED CT coded diagnosis of diabetes mellitus, and then selects a DMND coded medicine. So we'll stick with that metformin 500 milligram tablet. The GP system will also check for allergies and intolerances that are recorded in that system. We then have the transmission phase. So this is electronic prescription service. It sends structured prescription data to the nominated community pharmacy using FHIR messaging. So this is where the FHIR is coming into place. From the dispensing aspect, the community pharmacy receives that DMND coded prescription information, checks for interactions using summary care record as well, the allergies and the intolerances, and they still safely dispense this medication. So another safety net. And they dispense the medication. That same DMND coded prescription then gets submitted to the NHS Business Services Authority for reimbursement. So you can see that flow of those standards throughout this. And then finally, the visibility of this medication that's been prescribed and dispensed for this patient on the summary care record. It's updated with the new prescription details, which is now visible for urgent care settings and hospital settings alike. But it's not all smooth sailing. There's blockers in terms of achieving the full extent of interoperability that we want to aim for. So despite those clear standards and strategic intent, interoperability faces persistent challenges. And I've just got some of those on the screen. So coming back to what I was talking about, all those different systems that are used, fragmented systems, we've got legacy platforms, proprietary formats, and inconsistent upgrades across NHS trusts. Variable adoption of those standards that I've just spoken about, which means that they're not uniformly implemented or understood. Data quality issues, they're incomplete, outdated, poorly recorded, hinder the safe exchange of that medicine's data. We also need to think about our workforce. There's limited training in standards, literacy amongst clinicians and informaticians. If they don't know about them, how are they going to apply them? So there's that workforce gap that we need to address. Policy misalignment, so national mandates versus what local procurement decisions look like. And interoperability can sometimes be deprioritised at the local level. And then that cultural resistance. How often do we hear, well, my system works absolutely fine, why do we need to change it? We need to be, that mindset is also a barrier for moving forward. There's a lack of urgency and shared vision. So how can we break through the strategies to overcome interoperability barriers? So system modernisation, prioritising upgrades, and having systems that support the standards that I've already referred to. Mandating those standards compliance, so they might be available, it's then mandating the actual use of them, embed them into procurement, contracts and digital maturity assessments. Digital quality campaigns invest in structured coding, validation tools, and that clinical engagement. So I'll come back to those those workforce gaps that I've just referred to. Workforce upskilling, delivering sort of the CPD type modules related to the standards that enable medicines interoperability is an absolute vital part of getting this over the line. Policy harmonisation, so those local implementations, making sure that they are aligned with national strategy, which sounds obvious, but sometimes isn't always implemented. So that ultimately we have one vision and one vocabulary that we use across medicines. And then that culture shift. Promote shared accountability and showcase success, stories of joined up care. So what does this all mean for the future of digital medicines? Safer, smarter, seamless care is what we're ultimately wanting to achieve to keep our patients safe. So I'm referring to real-time medicine safety. So those allergy checks, those interaction alerts and duplicate prevention across all care settings. Yes, it happens today, but it's not instant. It's not information available at the time it's needed for that given patient, let alone the patient having to tell multiple clinicians the same story about their medicines. Joining up the workflow, so GPs, pharmacies, hospitals and social care systems, sharing that structured data effortlessly. AI enhanced prescribing, so think about a future where AI tells you exactly the medication that you need and you don't have to trial something to find out which one's going to suit you. This will offer that personalised evidence-based recommendation. Patient empowerment, individuals carry their SNOMED coded conditions and DMND prescriptions in their digital wallets. which is visible, portable, and secure. And then finally, informing population insights. So national analytics powered by interoperable data, driving smarter policy, safer formularies, and targeted interventions. Whistle-stop tour of medicines interoperability. Thank you.
Mindful of time and a break coming on, perhaps we have time for maybe one or two quick questions. Sebastian.
Just a quick, thanks very much. Great presentation, and I love this. I use it every day, and we all do. I was really interested to hear your comments about the future development for EPS. Recently we signed off the tracking service, which is there anything else coming over the horizon that may be of interest?
I think in terms, so you're right, we've got the prescription tracking service. So on the NHS app, if your GP has issued a prescription for you, you are able to track the journey of that prescription on the NHS app via the prescription tracking service is what it links to. And then there's an element that clinicians can see as well. Now, EPS has been available in primary care for years. Probably talking just shy of a decade, but it's only just come about in secondary care. So the advancement of EPS is already happening. EPS has only come about in secondary care since about 2022, 2023. So that transition from paper-based prescriptions is already moving towards EPS. But the advancements will now be that although you can order repeat prescriptions from your GP, you can't currently do that in secondary care. So yes, you might get an EPS prescription. You can go straight to your community pharmacy to pick up that prescription. But what you can't do is tell your secondary care provider, such as a mental health organisation that I work for, I need a repeat prescription of X medicine for myself, let alone ordering repeat prescriptions for some of our services where we've deployed EPS in our organisation for our ADHD young people. The ability to just be able to reorder their medication rather than having to go through loops and holes to make sure you have a supply of medication for your patients. So the advancement is taking EPS to the next level, deploying it across the nation in secondary care, and then building on that to reap the benefits of EPS to the extreme.
Okay, and just
actually, you already touched the aspect I was about mentioning on, which is the aspect of the mental health, because I currently work for a mental health hospital and really looking at that bit. But the other bit I also want to clarify on is England or NHS in England as a whole, what's the proportion of, do we have any of the NHS trusts that is secondary care that is currently on the EPS, and what's the percentage like?
Okay, so the organisations that I'm aware of, first of all, just from the ICS that I work in, which is North East London, all 5 of our organisations within our ICS are using EPS already. Okay, like I say, EPS in secondary care came about in about 22-23 as a first of type scheme, and Midlands Partnership Trust, and I'm sure they won't mind me actually saying this, they were the first of type for developing EPS with a supplier back in 2022. Now that breadth of organisations that are implementing EPS is growing. Second to that, the digital medicines team within NHS England have also developed further first of type schemes, and we are forming one of those where we are looking at other suppliers outside of one. I think there is a second supplier now that's been accredited in secondary care for EPS just this year, but there are more suppliers on the journey towards delivering EPS, so that percentage, which at the moment is very small, and apologies, I don't have a specific figure for you, but that gives you an idea, we can then expand EPS across secondary care.
I've been told.
When they issue the DMA results finally, or you hack it like I do, it will give you the breakdown of which organisations are using EPS. The challenge around that is how many people are actually using it fully and get rid of FP completely against actually just having the system capable. I don't think it differentiates, but that will give a view of size and scale.
Lots of interest.